Hello, my name is Aaron Petra. I'm a physician assistant working at the Institute for Minimally Invasive Spine Surgery here in Holyoke, Massachusetts. We operate out of Holyoke Medical Center with our attending neurosurgeon, Dr. Pennings, and today we're going to be going over the minimally invasive lumbar decompression. So some common indications for surgery. The most common is central spinal stenosis. This is an MRI image of spinal stenosis at L4-5. And the right-hand side where the red arrow is, you can see the severe compression on the thecal sac at L4-5. Oftentimes, imaging like this, patients will have what's called neurogenic claudication, where they experience pain, cramping, sometimes numbness and tingling, primarily associated with prolonged walking, and our patients will need to sit down and rest after very short periods of walking in order to continue ambulating. On the right-hand side, we see an example of foraminal stenosis, which is also a common indication for this surgery. And this is actually a CT scan of the lumbar spine. And you can see where the black arrow is pointing, there are osteophytes, or little pieces of bone that are actually growing into the hole or the foramen where the nerves come out. So some potential benefits of surgery. So resolution of that neurogenic claudication that we were just discussing, resolution of severe leg pain. Occasionally there will be resolution of numbness and tingling in the legs. It's difficult to accurately predict how much this will improve after surgery, as sometimes numbness and tingling is a sign of nerve damage versus nerve compression. Patients often have improved gait, they can walk for longer distances, and they have improved strength. For the expected hospital course, you'll arrive the day of surgery. You'll check in with our preoperative department and meet our nursing staff. You'll get to see Dr. Pennings before your surgery and sign a surgical consent form. You'll meet with our anesthesia team to ensure that you're safe to go under for general anesthesia for your surgery. Once the procedure is complete, you'll wake up in our PACU, our post-anesthesia care unit, and then you'll return home once you're stabilized with the help of our nursing staff, usually mid to late afternoon. For the surgical procedure itself, after intubation, we place you on this bed here called a Wilson frame. We sterilize the surgical site with iodine, and we take a timeout to confirm patient information and the proposed procedure. For the surgical approach, Dr. Pennings is a spine fellowship trained minimally invasive surgeon. Therefore, our openings are very small. On the right hand side, you'll see MISS incision, so about 0 to 1 inches. In a typical open version of this surgery, the patient may have a 3-4 inch incision, probably not as big as a 6-inch incision, but still much larger, much more trauma from your standard open spine surgery approach. This is an example of a laminectomy defect. So essentially the whole lamina has been removed off the back of the spine. That's what you would typically see in a standard open spine surgery procedure. We utilize minimally invasive openings, and typically we do what's called a laminotomy, which is about the size of this little red dot that just appeared on the screen. We only make a small hole in the bone and use tiny little micro instruments to get through there to decompress the nerve just like it would be decompressed from an open surgery. After the laminotomy is performed, Dr. Pennings will begin to remove pieces of ligament, bone, and tissue that are compressing on the thecal sac until we can see adequate decompression of the nerves. We're able to see this because we utilize a large microscope that hangs down from the ceiling, and we can see through those tiny little openings to evaluate the nervous structures as we're doing surgery. After the surgery is complete and Dr. Pennings is satisfied with the nerve decompression that's taken place, we'll close the incision with sutures placed underneath the skin and put a small layer of steri strips over the top, so there shouldn't be a need for suture removal after surgery. And for recovery and follow-up, your bandage can be removed on post-op day 1, so it's the day after surgery, but your steri strips will stay on for about a week after surgery. If they don't fall off on their own, we ask that you take them off after about 7 days. You'll need to observe about an 8 to 12 pound weight restriction for the first few weeks after surgery. Limit bending, twisting, and lifting. Walk as much as you can and get back into regular ADLs slowly. Utilize over-the-counter medications such as Tylenol or ibuprofen, alongside prescription pain medications that we send in for you. After that, you'll follow up in clinic in about 2 to 3 weeks for your first post-operative appointment. Typically, we utilize this appointment to ensure there is nothing grossly wrong, such as exacerbations of pain, issues with the incision, or need for subsequent prescriptions. And that is our overview of the minimally invasive lumbar decompression. If you have any questions, please feel free to reach out to us in clinic. Thank you for your time.